All right. Welcome, everyone. Welcome. We're just going to give it another few minutes as people are popping in. So if you could, while people are coming in, let us know, where are you joining from today? All right. Okay. I'm going to go ahead and get this started. All right, everybody. Welcome, welcome, welcome. Welcome to today's webinar, SABCS Highlight Part 2, Latest Ways to Think About Low-Risk DCIS. I am Megan Claire Chase, and I am Cher's Breast Cancer Program Director and host of our BC Life podcast, and I'm a 9-year breast cancer survivor. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping rules for you. All participants, you will be muted during this presentation. As a reminder, the chat is enabled, so feel free to write comments and engage with each other, but make sure that you select everyone in the drop-down box so we can all see what you're saying. There will be a short Q&A after each presenter today as we go. We'll do about 1 to 2 questions, and then once all are finished presenting, we'll get to as many remaining questions as possible. So please submit any questions that you have through the Q&A section at the bottom of your screen. Remember that our speakers are not able to give specific medical advice, so make sure to keep your questions general. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of your screen and selecting the subtitle option. This webinar is being recorded, and we'll share that recording in a few weeks with all of the registrants, and it'll also be added to our website. So now I would like to hand it over to our fabulous speakers to introduce themselves, starting with Deborah, who will kick it off. Deb, the screen is yours.
Okay, thank you, Megan Claire. I need permission to share with share. Okay, let's see. There we go. Is that the right screen?
Perfect.
Okay, great. All right, everyone. It's great to talk with you today. I don't know if you were there for the presentation that we had on part 1, but Dr. Shelley Wong and I were involved in that, talking about the COMET study. We're going to give you a brief review of the COMET study here in just a little while. But first, we wanted to go through and talk about what is it that is DCIS for those of you that may not be as familiar for it. Ductal carcinoma in situ is actually a breast condition that has abnormal cells, but they stay in the breast duct. As you can see right here, this is DCIS. So it goes from being a normal cells in a breast duct where milk comes from to DCIS. And then if it's invasive breast cancer, the cells break out from the duct itself. Okay. Carcinoma or cancer just means disease where the cells are growing uncontrollably. So that's what cancer is. So we actually distinguish low risk DCIS as a breast condition, but we'll talk more about that here in just a minute. So there are lots of different names for DCIS, right? And so I don't know what you've heard of. Feel free to put that in chat also if you'd like. But it's called everything from pre-invasive to precancerous, non-cancerous, non-invasive, intraductal carcinoma, and that's different than invasive ductal. Non-obligate precursor is one of my favorites. It's like, what the heck is that? And stage 0 and or a breast disease or condition. There are lots of different types of breast conditions. Some of them even have carcinoma in their name, but they're still not considered breast cancer. So anyway, you'll hear more about that. DCIS has become very prevalent since mammography started in the 80s, and each year it's increased a bit. I believe now it's 1 in 5 of the breast cancer diagnoses that we use in the statistics and talk about how many women have breast cancer, quote unquote, actually includes women who have DCIS as well. So they're a little skewed, but that's what we're talking about. We know that DCIS is not as dangerous, quote unquote, or as risky as invasive breast cancer, because even though there's more DCIS that's been found on mammography since the 80s, the rate of overall survival or the amount of deaths has not gone up. So it's women who have invasive breast cancer who who have issues with overall survival or may die from their disease. So that means that a lot of women are overtreated, and it's been estimated that about 3 in 10 women actually get more treatment than they need. And the reason for that is because most people with DCIS, and there are a few men, it's mostly women, are treated as if they have stage 1 or stage 2 breast cancer, but they don't. And it's very clear in the research that we've done, even though we're not showing all, well, actually I have one screen in a little while that'll show you what we mean by that. So what do we mean by low risk? Well, low risk includes different grades. And you can see in this picture here, this is what a pathologist looks at under a microscope to try to identify what type of DCIS you might have. So DCIS is graded. This is more normal looking. So this is the closest to what normal breast duct cells look like. Grade 2, as you can see, is a little more disorganized, and grade 3 actually gets more uncontrolled and starts to look a little bit more like invasive breast cancer. So that's why it's considered higher risk. Low risk is grades 1 or 2. The low risk factors include women who are at or over 40 years old in age when they are diagnosed. Clear margins, what that means is when the surgeon takes out the DCIS, there is a clear mark of normal cells around the piece of tissue, body tissue that they took out. And then also hormone receptor positive. So if you've heard anything about estrogen receptor or progesterone receptor, those two combined are called hormone receptors. And if you are ER/PR positive, you're at lower risk than if you are negative. And then HER2 is one of the other biomarkers that that we look at in the breast world. And HER2 negative has a lower risk to it than if you are HER2 positive. So that's what all of that means. And as you can see here, these grades can also be called low grade, intermediate grade, and high grade. Oops, sorry, I went too far. So that's kind of the way to think about this. We know now, thanks to research, that there are different types of DCIS. So that's why we've now categorized low risk, and higher risk. It's not that you're actually at high risk, and you'll see that here in a moment as well. So I thought this was a really good quote from Dr. McIntosh about low risk DCIS. And she was actually is one of the investigators in the COMET study. And her quote is basically that low and intermediate grades, or grades 1 and 2, are considered low risk with the lowest chance of getting either an invasive cancer or getting a recurrence of DCIS. And, there is a lot of evidence now that shows that DCIS grows very slowly, and women usually die of something else. It doesn't cause health problems. And in fact, um, this is just a reminder here about the risk factors. This was a study that was done it's very difficult to know what happens to women who are not treated, because most women are treated, especially in the US. And so this was a little older study, but it still holds true. All grades of DCIS. This is a chart that shows all the women that were in this particular study, and the solid line up above is women who got surgery, and the bottom line, the dotted line, is those who did not get surgery. So this is one of the very few studies that actually followed women who did not get surgery over a 10-year period and found out what happened to them. What they found out was for grade 1 DCIS, there was hardly any difference at all. You can see there with the lines, they're overlapping. What that means is it didn't matter whether or not they got surgery. They had about the same rates, and you can see it's very high. Over 98% of those women lived over a 10-year period without any additional breast event. Okay, so that means no more DCIS, no more invasive breast cancer. The group who were grade 2 had more of kind of the overall list. So the women who did not have surgery, there were a few more that did get either DCIS or invasive breast cancer, and they had a little bit lower survival. But you see these numbers on the side. This means 100%, 1.0. 0.8 means 80%. So you can see here, it was about 95% for them, if you follow the line. And then grade 3, even though the risk was higher, they still had good overall survival at about 90%. So grade 3 is more serious than grade 1, but it doesn't mean women with grade 3 will get invasive breast cancer or even another DCIS. And their life expectancy, I didn't put this research in, but life expectancy for women with DCIS is actually higher than it is for just the general population, believe it or not. And that's usually because you're getting checked more often, right? You're taking care of health issues that come up because you're getting checked, where other women who are, quote, healthy, may or may not go to the doctor on a regular basis. So this is just to emphasize for you that, we think, and we being patient advocates who have been a part of some of these DCIS studies, and Liz and I are both in the patient leadership team for the COMET study, for example, believe that we need to start changing terminology. Now, as you guys know, it's not just for those of us in the patient community that need to think about this differently. We actually have to teach our healthcare providers as well. And so we need everybody to kind of think about this. And I'm not going to go through all of these terms, but just to give you an idea, the left side is the way that DCIS is currently talked about, which unfortunately, when you hear you have DCIS, it sounds like you have breast cancer, because every term that you hear is cancer related. Every potential treatment has been cancer related, when in fact, there are different kinds of DCIS. It is a breast condition. It's always important when you're looking at research or talking to a doctor to understand what the absolute risk is to you as an individual, instead of the relative risk that's often used in the studies. an example of that would be, to the risk reduction study many years ago that looked at tamoxifen in women that did not have breast cancer and then looked at how many had it afterwards. They said that women that took tamoxifen had a 50% reduction in risk, which sounds huge. But what that meant is their risk went from a 2.6% to a 1.3% over 10 years. And so, you have to look at what is my risk anyway, and how would this impact me? So we just wanted to give a little bit of background on DCIS before we went into the COMET study itself, that both Liz and Shoshana will do. So Megan Claire, do we have any questions?
Yes, we do. So, the one that was submitted live, can you talk about re-radiation for recurrent DCIS is one of our questions.
Okay. I'm not a doctor and I don't give medical advice, but what I can tell you is and actually in the COMET study, radiation was not a part of the study itself. So you and your doctor have uh, an important role to play here in shared decision making. And a lot of women who have DCIS will go ahead and decide not only after surgery, but to have radiation as well. Sometimes that's the first step around. If there is a DCIS recurrence, most of the doctors that I know would probably feel better about recommending radiation after removing the second DCIS. I don't know, Liz or Shoshana, do you guys have any thoughts on that?
No, I think the point that Deborah is making is that physicians will try never to radiate the same skin again. So if you can delay something for when you might really need to have it, as opposed to when it's much more optional, that's often the choice.
Yeah, that's a really good point, Liz. And the fact is, you can only have a certain amount of radiation in one part of your body for the rest of your life. So that's actually important when you are first diagnosed with DCIS to actually have that discussion and think about that as well.
I'm going to go to this next one. And again, everyone, if we don't get to it in this moment, we will get to it at the larger Q&A at the end. This one says, your chart shows 98.8% survival surgery versus 98.6% survival non-surgery at 10 years. Not surprising, as likelihood of actually dying from breast cancer in 10 years when only having DCIS is very small. What are the percentages for what percent of women develop an invasive breast cancer within 10 years for those non-surgery versus those with surgery? How many women was that study based on?
Actually, that's a good question. I'm not sure, and I don't know, Liz or Shoshana, if you know. Does it say? Oh, yeah, down at the bottom here. Number at risk. There were 56,000 that got surgery. There were over 1,100 people, 1,100 who did not get surgery. So you can see, and then they're broken out here. So that's the total number. And then you can see how many had grade 1, grade 2, or grade 3 here. So that's what these numbers are based on. As I said, it's very difficult to do these studies because most women are treated in the US.
We should also point out that these kinds of studies are called retrospective studies. So they're looking back at medical data, and you need to do it because it's one way of collecting evidence. It's a responsible way of doing it, but also one needs to know that when they do it, you're looking at medical records. You don't know exactly how they were coded. There may be mistakes in them, so that you think about this as being interesting, important data, but maybe not as accurate as prospective data where you have more control.
Right. And the COMET study was prospective, which means following all of the women who were enrolled in that study joined currently, right? So that we could do a good comparison of how people were being treated in the same ways, and et cetera. So Liz will be talking a little bit more about that. And I don't know, did that answer the whole question? Oh, how many got invasive breast cancer? I believe the rate for invasive breast cancer with DCIS, and unfortunately, we don't have a lot of information about the different grades, like how many women with grade 1 get invasive, how many with grade 2. We know overall DCIS, and half of which is going to be grade 3. It's less than 20% of women, so 2 out of 10 may get invasive breast cancer in a 10-year period. The thing to know about that is most of the time, certainly not 100%, life is not 100% guaranteed, but most of the time, those women have low stage invasive breast cancer. So like stage 1 or 2, rather than stage 3 or 4, which is metastatic. So the death rate, I can tell you, based off of old things, is like 0.1% of women who have DCIS who will end up dying of breast cancer. 0.1, not 1%, 0.1%. So it's a very, very low. We need to think more about heart disease and diabetes and things like that, about survival, than about DCIS in most cases. Again, this is, nothing that we say is 100% for every single woman or man who gets DCIS. Okay, I think maybe we should move on.
Yep.
Okay. Let me get the slide, and Liz is going to take over.
Okay, hi, everybody. So I'm going to briefly review the COMET study, which is a large phase 3 clinical trial designed to ask whether active surveillance, or we call it active monitoring, is a reasonable strategy to pursue for patients who are interested in possibly not having surgery. Participants for the COMET study were over 40 years old, and importantly, they all had low-risk DCIS. In patients, so if you participated in the COMET study, you had an equal chance of being randomized to either what we call guideline concordant care, which is another one of these crazy phrases. It basically means standard of care, and in this case of DCIS, it means surgery. So you would either be potentially randomized to what you and your doctor would normally do if it wasn't a clinical trial, likely surgery, or the question that COMET was asking, active monitoring, which is watching and monitoring what's happening with DCIS, but not necessarily having surgery. The trial was designed as something called if you look at the top green arrow, you see prospective. That means looking forward, not looking backwards at things that have already happened, like the study that Deb was talking about. Randomized, which means that participants have an equal chance of getting either treatment or being in either arm, so that they're well matched for comparing. And a non-inferiority trial, which is also strange sounding, but what it really means that it's a trial asking whether each of these possible strategies are similar. In the way we refer to it statistically is are not worse than or are not inferior to each other. So at any rate, the study the first 2 years of the study were completed fairly recently, and they were presented at San Antonio, a large conference focused on breast cancer that many of you might have heard about or attended. And generally speaking, the 2-year results show that active monitoring is not inferior or is similar to surgery at 2 years. Clinically, and Shoshana is going to be talking more about the results, and I'm going to be talking more about the results in more detail in the next slide. But let's look and see what else is going on in low-risk DCIS. Deb, can you change the slide, please? Okay, so somebody could reasonably ask, so what else have we recently learned about low risk DCIS? And what we see here is that actually fairly recently there have been 4 trials around internationally looking at looking at low risk DCIS and asking the same question about active monitoring being a reasonable strategy. And what you can see here is COMET there are 3 studies of the 4 studies, 1 of them turned into a registry. So it's just really watching women who have chosen DCIS, who have chosen active monitoring. And the other 3, COMET is the first one to actually report out or reach its first primary endpoint. You might be interested to know that the COMET study is actually coordinating and has been coordinating with both Loris and Lord from the actually beginning design of the study so that we will be able to compare and contrast outcomes when each of the studies has reported out. But the important point here is COMET is the first large randomized study to show results. Next one. So, as we said, the first results were reported out last December, and importantly, these are 2-year results. And if we look at just the points on the right, we see that at 2 years, the primary outcome was what percentage of participants would have invasive cancer. And we learned that in the surgery arm, 5.9% at 2 years had invasive cancer, and 4.2% in the active monitoring arm had invasive cancer. And you might look at that and go, oh my goodness, why would active monitoring be lower? Well, in this trial, the way you look at it is they're actually statistically similar. Even though they look like they're numerically lower, we can't have confidence in that. We have to say they're probably similar to each other, and that little bit higher rate in the surgery arm might just be because that invasive cancer was found at the time of surgery. It might have been there to begin with. So we are actually very pleased to be able to report out that at 2 years, it looks like active monitoring is equally safe to surgery. And the other point here is that patients were given the choice in the COMET study of having any kind of endocrine or hormonal therapy. It was not part of the trial. Basically, it was left to patients and their providers to talk about whether they wanted to have endocrine or hormonal therapy if they chose active monitoring. And actually 50% of the patients did choose it. And that might also help explain the low rates, but we don't actually know that. And importantly, what we look at when we look at these 2 rates of invasive cancer is we look at 2 years. We look at 2 years of follow-up, whereas the COMET study actually has 5 years of follow-up planned. So with that, let's go to the next slide here. Okay, so as we said, follow-up will continue on the COMET study for at least 5 years. And the team is currently working on finding funding for up to 10 years because we all know that we would like longer results. And when in 5 years, we can all expect another presentation, either at San Antonio or at another very large meeting. And for those of you who are interested in learning more about the COMET results, you can look at these 2 little photos. They were published. There was one was published by Dr. Wang, looking at clinical outcomes, and a second paper was published by Dr. Partridge and group looking at patient-reported outcomes, which again, Dr. Rosenberg will be talking about after this section. And then for those people that are interested in just learning more about DCIS and what's happening with the COMET study, as well as there's also other studies and other publications about low-risk DCIS on this website. There's a website called DCISoptions.org. And we would encourage you to visit that study if you're interested in learning more about both low-risk DCIS and about the COMET study in general. So with that, we'd be happy to take some questions.
Thank you so much. Let's see. Is there anything immediately practice changing from these latest SABCS results presented on DCIS? Like, I know this is going to be like a 5-year study, but is there anything that that we're going to immediately see change?
So I think we can say with confidence that if you have low-risk DCIS, you should absolutely take your time to make a decision about what's going to work for you. So I think what's changed, hopefully with low-risk DCIS with these results, is letting patients know that they don't have to feel a sense of urgency if they have low-risk DCIS. They should feel like they actually have time to either consider active monitoring if they want to for the first several years, or just time in general to kind of think about their own personal values in their treatment decision. But these results are we would say that they will only take us out 2 years. They do not take us out longer than that.
Okay. And another question, so I'm like going in between previously submitted versus live right now. A question, can you talk a little bit about focal ductal carcinoma?
I cannot. I'm not sure if anybody else on this call can.
Well, I think what they're talking about, that's not a normal term that we hear all put together. But focal versus multifocal, for example. Focal means there's kind of one area, one point that has the DCIS in it. Multifocal means you could have many different pieces of DCIS throughout the breast and in the ducts, right? Because the ducts are like a tree. So they have, like the tree behind me, it has branches, right? So sometimes the DCIS will just be in one part of that branch. Sometimes it will be, kind of like the buds over here, where it may be in more than one place. That's multifocal.
Thank you, Deb. And again, everyone, we're gonna keep this going, and we're gonna get to some more questions. So, Shoshana, take it away.
Thanks, Megan, Claire. So I am going to share some of the results from the patient-reported outcomes component of the COMET study. The patient-reported outcomes, sometimes we just call it PROs for short, are what we collected as part of surveys that we administered to patients who enrolled onto COMET. For the first year, I believe we had a survey at baseline, so before patients were randomized, but when they enrolled, to get kind of a baseline measure of the different outcomes I'm going to share in a couple of minutes. And then over the first year, we again measured these same outcomes at 6 months, then a year, and then annually. And as Liz and Deb mentioned, just like for the primary outcome of the study, where we're following women for many years, 5 and hopefully longer. Similarly, for the patient-reported outcomes, we are also trying to capture these outcomes longer term, so we can also speak to how women report their quality of life is longer term. Next slide. So I just wanted to start with a brief definition of what a patient-reported outcome is. And this definition is from the FDA of all places, but I think it kind of summarizes really nicely what we mean when we say the term PRO. A PRO is a measurement that is based on a report that comes directly from the patient about a status of a patient's health condition without amendment and interpretation of the patient's response by a clinician or anyone else. A PRO can be measured by self-report or by an interview, provided that the interview records only the patient's response. And on the left-hand side, you see just a few examples of different types of PROs, quality of life, which is what we're going to talk about in the COMET study, other outcomes like financial burden, symptoms, health behaviors like smoking, physical activity. Often in trials and in other studies, we measure adherence or compliance with taking a medication, and we can do this with different patient-reported outcomes measures. And there's just a wide range of different patient-centered outcomes that are often captured with different PRO measures. Next. And PROs are used for different purposes and in different contexts, and these are just a couple of examples. We often, in the healthcare setting, use it for what we call quality purposes, trying to assess whether the care that's delivered is done so in the way it's intended. So that would be a quality measure. We do it to tailor or improve clinical and supportive care. And we often collect patient-recorded outcomes in the research setting, which is what we're talking about in the COMET study. And importantly, and this is very true for COMET, PROs can inform how we make decisions about treatment. So the PROs from the COMET study, this is a team effort. Deb, Liz, and many, many others were instrumental in pushing this part of the study through. And just for some background, we know from prior studies, different surveys that have been done, both in women with DCIS, who are often compared to women without a cancer. Some studies have actually looked at women with DCIS compared to patients with invasive breast cancer. But we do know that in these prior studies, those women with a history of DCIS have overall favorable quality of life, which is reassuring. We do sometimes see that there are certain deficits, like reduced vitality, some psychological health outcomes are sometimes compromised. There's often anxiety, understandably, that's higher following diagnosis. Fear of recurrence is also sometimes documented. Overall, though, these are relatively rare. In most prior studies have, in fact, found that those with DCIS have comparable psychosocial health and quality of life to women without DCIS. Sometimes women with DCIS who've had surgery or radiation do report arm symptoms and pain, and this is similar to what women with invasive breast cancer who have the same treatment also report. As Liz just presented, the primary results from the COMET study did show that women who pursued active monitoring as a management strategy did not, in fact, have worse outcomes than women who had surgery with or without radiation. And as Liz also mentioned, the COMET study is allowing us to prospectively evaluate patient-reported outcomes among women who had DCIS and did have surgery with or without radiation compared to those who only had active monitoring. So I just wanted to kind of lay out the study design. This was a randomized study, so it was random whether women who enrolled were allocated to a study arm where they received surgery or radiation, which was also called the guideline concordant care arm, or to the active monitoring arm. Overall, there were 957 eligible participants who were randomized. 471 were randomized or assigned to the surgery plus or minus radiation arm. And then 482 were assigned to the active monitoring arm. For our patient-reported outcomes that we're going to talk about here, we had an excellent response rate. So that means that almost everyone, 99.5%, did complete at least one survey as part of the study. And overall, when we think about survey research, we're also interested in how many people complete follow-up surveys. So we're able to evaluate changes over time. So for the COMET also, over 83% of patients responded to the survey at follow-up time points. So that's excellent. And it will enable us to really look at changes over time and report on longer term outcomes. Another just point about the survey response rates. We did also look whether there were differences among those patients who responded to the 2-year survey by different characteristics. And overall, it did not differ between the arm of the study that was randomized to guide-like and coordinated care and the active monitoring arm. So they were similar. And there were a couple of patient characteristics that were a little bit different between those people who responded to the baseline in the 2-year survey. So those who were older than age 65, those who were Black, and those who had a higher tumor grade were less likely to complete both the baseline and the 2-year survey. So I just wanted to briefly go over the specific PRO measures, and these are like the individual questions that are part of what we call survey instruments. These are measures we chose because other studies have used these before, so we know they work well. For quality of life, we used a measure called the SF36, which has been around for many, many years. And the SF36 has 36 questions. And these questions cover a range of different health outcomes, general health, physical functioning, emotional functioning, pain, mental health, so different outcomes. We also used a measure called the EQ5D, 5L. It's also a measure of overall quality of life as it relates to different physical functioning. And the questions are asked in a way that asks respondents to report how they're doing that day. So really daily functioning. For psychological emotional, we were specifically interested in evaluating anxiety. We used, again, a measure that's been used in many prior studies, the State Trait Anxiety Inventory. For depression, we used something called the CESD-10, so 10 individual questions that get at symptoms of depression. And then we also had some questions that were specific to worries about DCIS. Finally, we had questions about different symptoms, and these came from a measure called the Breast Cancer Prevention Trial Symptom Checklist. This got at hot flashes, nausea, bladder control, vaginal problems, musculoskeletal pain, cognitive issues, weight problems, and arm problems. And we also included a few questions about pain. Sorry, hopefully this is not too small for people viewing it on their screens. It's a little small for me. I have to lean in a little bit. But this is a table just summarizing the baseline participant characteristics of patients in the COMET study who completed the surveys. Again, we did not see many differences between the two arms. Deb, I think I have animation, so you could go ahead. So just first, briefly, age. Most participants in both arms were older than 55 years of age. About 25% were non-white, 16% overall were Black, and Hispanic overall were 5%. 19% reported being pre or perimenopausal. And now these are the main PRO results, quality of life. Again, we used a measure called the SF36, and we looked at changes in the scores on the SF36 over time. And just for context, the SF36, a score of 50 is what the general population, so people without DCIS, people without cancer, that's the average score, so score of 50. And you can see on kind of the left axis, we have, the bottom is at a score of 46. The top is a score of 54. So very, very small changes. You can see at baseline, it starts about 52. It goes down to about 50, stays that way. It's really very similar between groups. And again, this was not, this, when we did the statistical tests, these were not different. So that's reassuring. And then you could see these are only examples of 3 different scores. We have general health, physical components, and mental components. Again, overall, really good. You could see, for example, in the physical component score box that's labeled B, the lines are like even overlapping. So it gets a little bit worse over time, but you're comparing, as Liz mentioned before, the absolute difference. You're going from about a 51 to a 48, and that's not a clinically meaningful difference. So it looks a little bit different on the chart, but that's just because the scale is so small. And I just wanted to show one of the outcomes where, again, when we did the statistical tests, we did see a difference a little bit between groups. You can see at the point that's labeled month 12, the 2 lines separate a little bit. So it looks like
I'm so sorry to interrupt, but we had one question asking about what ARM meant. So can you just quickly, but as you're talking about
ARM
it,
is just another
thanks.
another word for group. So it's just another way of saying in clinical trial language, we often call it ARMS, but group means the same thing as group. So just to show, I want to show this as an example where we found a statistically significant difference, because you could see those 2 lines kind of separating a little bit at 12 months. But again, you move out to 2 years, 24 months, they really are overlapping again. So even though there was a little bit of a different pattern over time, again, very, very small differences, nothing that we would consider clinically meaningful, which is reassuring. Again, the same patterns for anxiety and depression. Overall, the levels of anxiety and depression were low. And again, we did not see any differences between the 2 groups over time. Menopausal and pain symptoms, again, reassuring, relatively low levels of symptoms reported. The 4 charts that we're showing are just an example of some of the symptoms. I gave you a whole list, but the patterns were largely consistent when we looked at all different types of symptoms. And we did not see any changes in symptoms over the 2-year follow-up. For pain, I just will quickly go through pain. I just wanted to point out for pain, we did see some scores that were higher at baseline. Sometimes just by chance, scores are higher in baseline, or maybe there's something that different about the group. We don't really know. We did see higher pain scores. Overall, again, they were low, but when we compared the 2 groups, they were a little bit higher in the active monitoring group compared to the guideline concordant care group. And that kind of, again, overall low, went up a little bit over time, but largely parallel, and really no difference in the pattern over time. So to summarize the results from the COMET study PROs, overall, I think reassuring. Overall quality of life was good. Anxiety, depression, breast cancer worries, symptom trajectories were all similar between the 2 randomized groups. And we did not see any evidence of substantial negative impact on these outcomes of one approach over the other, at least at 2 years. And I think kind of the take-home message is that for women who are considering active monitoring versus guideline concordant care for low-risk DCIS, both strategies have limited impact on the average of the lived experiences of patients. Again, at least in the short term, we are continuing to follow as we are for the primary outcome, like we talked about, for longer term quality of life outcomes as well. And just to thank the Comet team, you might recognize a few of those faces from many years ago. And of course, the participants and the research staff at all the study sites. This was really a big team effort. So we appreciate everyone's contribution.
Thank you so much. So just going to keep going with the questions here because we did receive some previously submitted questions that did ask about like the levels of stress and anxiety and kind of wondering, let's see, were they taking any other type of supplements or were they on any type of antidepressant as you know, getting that patient feedback of saying, you know, there was really no difference between the moods?
Yeah, great question. So we do collect a lot of that data. We have a lot of data. We did not look at very specific subgroups yet, but we do plan on looking more closely at different subgroups, who's at risk, who is taking certain medications to kind of better tease out, I think, answers to those questions, but we have not looked at it yet.
Okay. So the question here, and I'm gonna just read it.
Mhm.
Why do doctors tell patients with DCIS that the risk of dying from breast cancer is near zero if it is treated appropriately, typically with surgery, yet the 2-year COMET study found that 5.9% of women with DCIS who underwent surgery still developed breast cancer within 2 years? Can you clarify, talk about that?
They're talking about different endpoints. So when we talk about developing invasive breast cancer, it can be very low risk invasive breast cancer. We're not talking about any kind of a survival endpoint. So I think when doctors are talking to us as patients and they say, this is, at 5 years or at 10 years, they're comparable, they're often talking about overall survival. But Shoshana, do you or somebody else want to answer that question as well?
No, I think you answered it. Is that clarifying enough? Or I think what I was gonna just add, which I might be not answering this question, was in the surgery plus minus radiation group for COMET, many of the cancers were diagnosed in surgery, were upstaged, right? Like right when they had surgery. So some of those breast cancers were diagnosed right away because that happens in a percentage of DCI, which is initially diagnosed as DCIS upon surgery. There's always a percentage that on further pathology emerges breast cancer. And in the COMET study, if you look very closely at some of the I don't know which curves you presented, Liz, but it clearly shows that.
Yes, so I would just add to that because we didn't talk about upstaging. Upstaging is when they go in and surgery and they find invasive breast cancer, not just DCIS. That happened, I believe the percentage was 17% of the time in the surgery arm. That means 17 out of 100 women who got surgery ended up having an invasive breast cancer. For the most part, that was stage 1. That was not seen on mammography. The thing to think about there is the arm that had the women who had active monitoring instead of surgery could have some kind of invasive breast cancer that we can't see on mammography also, but they were getting mammograms every 6 months in the COMET study. We did that on purpose instead of yearly mammograms to make sure that it was a safe study and that if something else was going on in the breast that we didn't know about, it would be found early. And the thing also to remember about active monitoring or active surveillance, as it's sometimes called, is it doesn't mean you will never get surgery. It means you get it when you need it, right? In other words, you don't have to have immediate surgery for DCIS, perhaps. And we'll find out that when we get longer term follow-up, which I'll talk about in just a second too. But it means you get the surgery when you need it. So that's the main difference between the two arms. The other part I wanted to make sure we understand is why did we only do 2 years of follow-up so far versus why do we keep talking about continuing followed up? Research costs a lot of money. And so the COMET study and the funding that we got for the COMET study only covered the 2-year rate of did women get invasive breast cancer or not. It didn't cover 5 years. We had to go find additional funding from another source, a foundation, to get the money that's needed to continue to follow these women for that 5-year period. We're also searching for more funding and more dollars so that we can actually find out a 10-year period. But I think it's really important to understand that that's why you only see certain numbers in research studies and in reports and articles about them. It's all based on how much money does it take to continue to follow the trial participants. And we also want to make sure that everybody understands how important it was and how much we really appreciate the women who participated in this study and in other research studies, because that's the only way we find out these answers.
Ooh, as we're getting close to wrapping up, I'd love for each of you to give, 1 or 2 points that you want our participants here today to walk away with, because and just looking at the remainder of the questions, a lot of it is asking, well, what if DCIS is left untreated? Will it definitely become cancer? What about the terminology? Is that going to factor in with the COMET study for future results? How will that change the conversation between patient and doctor and diagnosis? So if you could just leave some things for our audience to walk away with today.
Shoshana, you want to start, and then Liz?
Sure. So I'll just speak from, a PRO perspective. I think, as I mentioned at the very beginning, PROs are very important for helping to inform treatment decisions. And I think in addition to kind of the data that I presented, kind of being reassuring overall, I think, this type of data can really be used in different types of communication tools or decision aids to kind of provide this information to newly diagnosed patients. So if they do have a choice about, different management strategies for a DCIS diagnosis, they can know this information ahead of time. I think that's, from my perspective, why PROs are so valuable, because it could really inform treatment decisions and expectations around treatment. What is my pain going to be like in 2 years and 4 years and 5 years? And if we could provide that information for newly diagnosed patients, I think that could really be valuable.
To me, I guess the message I would like for patients with DCIS to take home is that there is new evidence that suggests that their doctors may not be aware of. I think that's one of the things, and that this evidence should support their ability to kind of slow down the decision-making process. Okay. And that, so I think if, those of us who know people who will be diagnosed with DCIS or that are diagnosed with DCIS, it's very important to share these results, because it's new knowledge. It's not to say that it's the ultimate knowledge or that there won't be more knowledge, but it's really the best knowledge we have at this point. So that's
And-
my thought. Deb?
And I know there was a question about, is this going to change practice? And Liz covered that a little bit. We are hoping it will. 2-year follow-up data is not enough for a lot of doctors to feel comfortable. Because remember, for decades and decades, they've been treating it as if it's breast cancer, right? So it will take more evidence, which we're planning on building, but it also depends on what we talk about. So each person here has the ability to self-advocate for themselves, and as Liz said, to help their doctors learn more about what's happening with research and why this is actually something to consider. You will also have, we created a plain language summary of the publications. So we're going to be sending that out when Megan Claire alerts you about this recording. So please feel free to look at it. It's got the QR codes to the actual articles. Please feel free to share that with all of your providers, not just your surgeon or an oncologist, but also radiology. That's really important. And primary care physicians. We need everybody to understand this. So thank you very much for your awareness and attention, and we look forward to more discussions.
Well, thank you, Deb, Liz, Shoshana. We really appreciate your time, your expertise, and the way you have been able to, give us some more power back, I guess. Like, we have some next steps in the DCIS community, right? Like sharing the results of this, looking at the patient summary. So everyone, there will be a recording that'll be on our website, and then you'll be able to find it on our YouTube channel in about 1 to 2 weeks. And we'll make sure that we include all of that information that Deb just mentioned. And again, we want to make sure that you check out SHARE's website for upcoming webinars, supportive resources, and of course our support groups and our support helpline, and also our podcast, right? And also at the end of this, before we head on out, there is a survey that'll pop up. If you could please fill that out. It's anonymous. That's how we come up with topics for future programming. So make sure that you do that. And
Megan
again,
Claire,
oh,
I'm sorry to interrupt you. I just wanted to answer one more question that popped up really fast.
okay.
Why are we only doing 2-year follow-up when the study started in 2017? It's because we wait until everybody has been on the study. So it took many years to get almost 1,000 women enrolled in the study. And so that's when the 2-year, 5-year, et cetera, mark hits, is once there's follow-up for everybody.
Thank you so much, Deb. Whew, as we know, research, it's not quick, It's not quick, unfortunately. But everyone, thank you so much for joining us today. And again, thank you to our fabulous speakers. And this concludes our webinar. Y'all have a great rest of your week, and we'll see you next time.
Thank you.
Bye.